Good afternoon. My name is Paul Lilley from Hancock County, Ohio, and I'm with the Crisis Intervention Team in Findlay, Ohio, which is in Northwest Ohio. And today we're going to be presenting on de-escalating special populations. I think there's three reasons why this training is critical. The first is mental illness, and I'll get back to that in a second. The second reason is this is really a risk liability training. What you say and what you do as officers means something in encounters with special populations. The third reason is these skills save lives. They help you get home at night. Let's go back to mental illness. What other illness can you think of that we allow people to become so ravaged by the illness, so sick, that the first line of intervention is often law enforcement or criminal justice or sadly jail? That's why this training is needed. What we'll try and do is show how you can take control of these situations and increase the probability of a safe resolution. The overview for today's presentation is I'm going to address 4 encounter types. There's over 200 diagnoses in the Diagnostic Statistical Manual. That's the clinical Bible for therapists. You don't have to worry about that. There's all sorts of syndromes and disorders. You don't have to worry about that. When someone is in crisis, they will present in one of 4 ways, and we will cover that. 3 phases of every encounter. When you're in the encounter, there's really 3 areas and goals that you're trying to accomplish in that encounter. 2 safety skills, patience and empathy. That's going to be your backdrop for de-escalating. And 1 survival skill, vigilance. We want you to stay safe, and anything in this presentation has been set up to not compromise your safety. And we do that in part by looking at the de-escalation decision tree, which I'll do in a minute. First, I want to just define a few topics. Crisis, really, we're defining that as the person is in crisis. So what they're defining as a crisis situation is really kind of it. But it's generally a loss. It's a crisis built around loss of a loved one, loss of relationships, loss of jobs possibly, and can present itself in a variety of different ways. De-escalation, 2 of the most well-studied fields is behavior and communication, yet they're still very poorly understood. So this is still, when we talk about de-escalation, this is still a lot more art than it is science. Special populations. That's generally anyone exhibiting diminished capacity, and that's why mental illness plays such a crucial role in this. First thing I want to do is offset normal police encounters from those with diminished capacity. In the normal non-crisis encounter, our thinking, actions, and behavior and level of compliance are pretty straightforward. It's deliberate. Doesn't mean it's always not criminal. I steal a purse because I want money to buy drugs. It's still a logical sequence because I don't have diminished capacity. My actions and behavior, I exhibit a greater ability to control my behavior, and the level of compliance, I generally can respond to commands that are given to me if I don't have diminished capacity. In special populations encounters, however, the thinking isn't always deliberate. It's impaired, illogical, irrational. It may not be, the person themselves may not even be aware that they're ill. The actions and behaviors may seem odd, and we'll get into that. These are the observable characteristics that you're going to be looking at to know and recognize when you're in an encounter with special populations. And the level of compliance, they may not be fully in reality. They may not be fully compliant. They may not be able to even hear commands that you're giving to them if they're psychotic and hearing voices. So a non-crisis encounter, the behaviors are a choice. The thing that starts to set apart special populations is it's questionable. I mean, if you have diminished capacity, it's not always a direct 1 + 2 = 3 in terms of the behavior being a choice. It may be more a manifestation of the illness. So to summarize for special populations, we're talking about diminished capacity, and I want you to start thinking about diminished capacity as being medical encounters. The vigilance is these are unpredictable. Unlike a medical encounter, an officer arrives at a scene of a car accident where they're looking at broken legs. Sometimes de-escalating folks who are psychotic or suicidal, especially if they have a weapon, are very unpredictable. So we want the officer to stay vigilant, and that the crisis will manifest itself in one of 4 ways. One of the analogies we use when we talk about the medical encounter, we call this de-escalating special populations as kind of like CPR, the analogy of being CPR in medical encounters. This is CPR for the brain, if you will, for officers to use. And it is a risk liability training. We often talk about that as an analogy if you are sending your son or daughter to the city swimming pool and you learn that half of the lifeguards got trained in CPR and half didn't. It doesn't seem to make sense. I mean, this is such life-saving critical training that obviously you want all the lifeguards to be well-versed in CPR. One of the ways we make this about safety, and we keep vigilance right on the front line, is when officers arrive at a crisis situation, they're given usually 911 information if they're not just arriving to the scene, and they're constantly doing their assessment, their situational assessment, their powers of observations. They are really determining if there is a clear and present danger. If they get on the scene and that assessment is, in fact, there is a clear and present danger, there may be a presence of a weapon or weapons may be out, that officer is trained to de-escalate using his force continuum. We don't want to interrupt that. That gets you home at night. That's life-saving training. What we're saying, when you get to a crisis situation, and it in fact isn't a clear and present danger, it means you have time to de-escalate. And what we're trying to say with CIT, generally officers are trained to de-escalate using command and control tactics. Again, that works when you think about the non-crisis and the thinking is deliberate and the actions are deliberate. That works. And officers test that by the level of compliance to commands. But we have special populations training for a reason, because diminished capacity creates a different scenario for an officer than command and control. So what we're asking the CIT officer to do, or the officer that would be trained in special populations, is again, if diminished capacity is involved, we're saying this is a medical encounter. Now, when you think about a medical encounter, command and control doesn't seem to make sense. If we say that someone who is in the throes of depression and is suicidal, that it doesn't seem to make sense to use command and control to order them off of the bridge, for example. The officer may have to dig a little bit deeper for verbal de-escalation skills to try and get the person in despair off the bridge. Said differently, if you encounter someone who's psychotic, command and control techniques about trying to break through their psychosis and what they're hearing and seeing aren't always effective, and in fact can escalate a situation. So that's one of the things we want to get back to. What you say or do in these types of situations matter, meaning they can escalate or de-escalate a situation. Generally, taking command and control techniques to medical encounters can escalate a situation. The force continuum is taught by officers when they arrive on the scene as just their very presence, the belt, the gun, the pepper spray, the taser, the actual weapon itself. Then they use commands. If compliance isn't there, they're taught to go soft hands, hard hands, a whole range of less lethal, pepper spray, baton, taser, before they have to go fully with lethal force. We're going to start by looking at a video, and I want you to start thinking about diminished capacity, and in this video, do 2 things. Look at what's happening with the subject and be able to describe to me what makes this a special encounter population. And then think about officer safety. Again, we want to focus on vigilance, and tell me if this was a good encounter.
Get rocking. I am from the tribe of Issachar. Daughters of Baal, you must be baptized in the name of God. Adam's son, come here and accept Muhammad as your savior. Come here, Adam. Come here, Adam. Ishmael will save you. What are you doing here, sons of
Go
Satan?
around here.
Get back
Hey,
or be
buddy.
baptized. Get back or be
What's going on
baptized.
out here? Hey,
Stay back. Stick.
hey, I'm Officer Lee with HPD. What's going on?
Stick.
What's going on?
Don't hurt me.
What's wrong, man?
I am the son of Satan.
Look,
You
I'm
must
Officer
be
Lee
baptized.
with HPD.
You
What's
must
going
be
on out here?
baptized in the blood of Satan. Hell. Police. Damnation.
Come
You
on,
mu-
buddy.
What
Hey.
are you doing back there? What are you trying to hurt me? Are you putting a chip in my brain?
What
You
are
trying to read
crazy,
my
man?
thoughts?
We don't do no microchips.
Are
Hey,
you
buddy,
trying to
what's
read
your
my
name?
thoughts?
You crazy?
What's your name? What's your name?
My name is Jesus fucking Christ. What are you doing?
Hey, hey,
Get back.
don't be
Get
talking
back.
like that, okay?
What? Get back.
Hey.
Don't put
Hey.
that chip in my brain. Don't put that
What,
chip
are
in
you
my
crazy? We're
Get
not
back.
putting any chips in
Get
anybody's
back.
brain.
What's your name, buddy?
man?
Get back. Jesus fucking
What's your name?
Christ.
Don't be talking like that, all right?
Get
My
back.
partner asked you a question. I want you to answer.
All right, so let's look at that as a special populations encounter and look at the observable characteristics. This is where I'd ask, what did you see? What did you see the guy exhibit that puts this in the category of special populations?
It was acting odd.
Say more about it. What was odd?
His dress.
Did it-
Everybody else was in summer clothes. He was-
Long coat, and yep, okay. Dress is good.
Method of communication,
And what was it for that gentleman?
confessing,
Swearing, a little belligerent it looked like. What else? Remember, medical encounter, diminished capacity.
He was
not able to follow commands.
Delusional, meaning spike in my neck, hearing,
our brain.
yeah, big sign, untreated mental illness, medical encounter. If you think about officer safety now, was this a good encounter?
Not
Eh.
necessarily.
Everybody got home safe. Tell me about officer safety, how it could have been more safe.
Well, the officers approached him from two different directions, and they didn't give any room for de-escalation. And
So their effort in verbal communication was short.
correct.
What did you hear in terms of verbal de-escalation other than, hey, what's your name, and quit doing that, and I mean,
He was raising his voice, giving his commands.
right, louder. And I mean, that's kind of what we're taught with command and control. If they're not listening, I'm going to raise my voice. And again, this is another one of those areas where how officers are traditionally trained can backfire in a special populations encounter. I would argue for officer safety, how did they resolve that? If you think about the use of force continuum, officer presence didn't work, commands didn't work, they went hands-on before they frisked
Doing
them,
the searches.
before they knew what was under the long coat. And you notice in terms of his dress with how the weather and the time of season in terms of what he was wearing, it isn't uncommon for those officer encounters that result in death, that make the newspaper headlines. It involves a screwdriver, a weapon, a rod, things that are bought out of the code. So I would argue for officer safety, if they could have gotten voluntary compliance and began to forecast, and I'm going to have to pat you down, sir, assume the position, so to speak, so they could have voluntarily checked him out, it would have been a much safer situation for the officer. So this is critical because you're starting to see special populations as a medical encounter. In this case, it looked like untreated delusions. But also, again, just to really reinforce that what you say and do can inflame if you rely on command and control techniques for a medical encounter. So we talked about some of the observable characteristics that this gentleman showed. He was psychotic, which is a clinical term meaning he was not in touch with reality. That's why he thought there was a demon horn in the back and brain chips. And generally, folks that are out of touch with reality can be withdrawn. The delusions is false beliefs, disorganized thinking, all sorts of hallucinations. They could be visual, where I'm seeing things. They could be auditory, where I'm hearing things. Odd behaviors or mannerisms, you kind of saw that in his speech. You saw that both with his body movement as the officers were coming in to get him. Suspicious, paranoia, fearful. This together makes up a profile of an encounter. When I say that there's over 200 disorders in the DSM, but we don't have to teach you what those are, what I have to teach you is what does it look like when someone's in a crisis. And someone that we're calling special populations will show behaviorally things you can observe one of 4 ways. So this is our first way, the loss of reality. And I want to cement again, medical encounters, diminished capacity, command and control techniques can escalate a situation. We saw that in the movie with the officer's presence. We saw as the officers were triangulating the citizen, he was reacting to that, especially the guy, for whatever reason, behind him, holding up the Bible. Over-reliance on commands to get compliance. You had mentioned the depth or lack thereof of their verbal de-escalation skills other than, hey, what you doing, asking his name, and then just kind of using commands to try and get compliance. I am not saying that you shouldn't arrive on a scene and not use commands. Definitely use them. But you'll be able to quickly see how someone is reacting to that. If it's getting you compliance, go with it. That's what you want. If it's not getting you compliance, you're going to need to dig deeper with some of the verbal de-escalation skills we'll show you. Hands-on touching, and then, again, this would be what I'd say was a big risk for officer safety that we saw. And I would generally characterize, and that's not what we're looking for in our officers. I mean, we're not necessarily wanting them to show empathy and patience when they are using command and control. Again, command and control works for the 90% of encounters that aren't special populations encounters. We're not bashing that type of training. It works. It gets you home at night. What we're trying to say is when you recognize a special populations encounter, you need to know that your very training, and by the way, this is still the force continuum that we just saw. Presence, commands, hands-on, before they start getting to less lethal and lethal. This very training is what can escalate a situation with special populations. Again, another way of saying how critical this training is. Why confrontation doesn't work? Always, again, more art than science. We rarely say never and always in situations where we're talking about what you're doing in the heat of battle or in the heat of the encounter. Because again, it's more art than science. It's dealing with behavior, so we don't always know. We kind of showed how logic and the ability to reason are compromised. And again, this is cementing why the command and control techniques might not work and in fact can escalate the situation. Disorganized thinking causes difficulty following the request. They might be paranoid of you. They might be paranoid of the badge, of the gun, of the very presence of you. So right from the get-go, out of the gate, you can be increasing the level of anxiety just based on showing up. And it's really less non-compliance, again, medical encounter, special populations. It's less about I'm not conforming to your wishes or a power struggle as it might be in a normal conflict, and more about what makes it about a special populations encounter. Again, that diminished capacity. So that leads us to the de-escalation paradox based on how you are trained. Again, in those 90% of the calls, we want you to get to the scene. I want you to get to the scene and resolve it quickly with compliance. So command and control techniques work there. The paradox with special populations is if that's what you go in with, you are increasing the probability of possibly a conflict. So by taking a less physical, less authoritative, less controlling, less confrontational approach, you'll have more authority and control. This is what we want to give you. This is what gets you home at night in these encounters. More authority and control, again, the skill set, patience, and empathy in terms of the de-escalation mindset. The other way we say this is these skill sets increase the probability of a safer resolution for you. So we've just changed the decision tree, the de-escalation decision tree. 90% of those calls, you're staying on this side. If there's a threat assessment, when we get to this, is this a medical encounter, a psychiatric crisis? Does it involve diminished capacity? All of those work together. If not, we still want you to de-escalate using command and control techniques. If it is, we're going to want you to de-escalate using specialized skill set. We've already talked about the mindset, kind of being patience and empathy. That's the backdrop for how you will actually deliver the skill set. All right, so we talked about one of the 4 profiles, loss of reality. The other profile, the second profile, is loss of control. This would look like someone who is ready to fight. Sometimes the manic stages of bipolar disorder, sometimes personality disorders will exhibit themselves in folks being aggressive, assertive, manipulative, destructive, oppositional, argumentative. This is a profile an officer generally within the first 3-4 seconds of an encounter. If someone is exhibiting that, it's pretty easy to see that. You begin to see how this is a little different than what we just saw in the video. Someone that's not in touch with reality. Different things the officer's going to have to de-escalate, the confusion. They're going to have to break through the psychosis with their skill set. This is a little different. You have someone who's pissed, and you have to deal with that in terms of de-escalating that. The third, so we have loss of reality, loss of control. The third encounter type is loss of hope. These would be encounters where officers arrive at the scene and the person is just anguished, sad, despondent. Sometimes these are a real struggle for de-escalation because the person is barely verbal. It's really hard for the officer to pull information out of someone in a loss of hope category. And for the fourth and final category, I want you to take a look at this video. And again, focus in on the observable characteristics. So we're already assuming it's not going to look like loss of control, loss of reality, or loss of hope. This would be our final category. And tell me what the observable characteristics are that you see.
There's no guns or anything in there, but there's
Hello?
You get out of here!
Sally Ann, can I come in?
Get out of here!
My name
Get
is
out
Paul
of here.
Micho, and I'm the
Oh, now
CIT
he's called
officer,
the goddamn
Presence
cops.
Prevention Team.
The CIT officer introduces himself first and calls the person in crisis by name.
I can see that you're upset, but I'm here to help you.
Notice the CIT officer uses I statements to convey that he is listening, he empathizes, and he cares.
I am upset. You would be too if your brother was trying to poison you. You make him leave. He's trying to poison me. I don't want to take that medication anymore. It's making me sick.
So, Sally Ann, what you're saying is that the medication makes you sick.
Yes, it does.
The CIT officer stays calm and focused and continues to attempt to resolve the situation without a confrontation. He restates Sally Ann's concerns, showing that he is listening and understands.
Because I'm sick with the medication, and he's sick. I'm sick.
So it has a lot of side effects, is what you're saying?
Yes.
Here, the CIT officer reflects Sally Ann's feelings in an attempt to comfort her. Paraphrasing is also a useful technique. It reassures the person that the CIT officer has a grasp of the crisis at hand.
It does make me sick, and it made me gain all this weight, and it makes my mouth dry. I can hardly, and I don't want to go to jail.
Let's talk about it and see how maybe we could talk about your doctor and see if we can get you some other medication that might make you feel better. Do you think that might be a solution? Come on, Sally, let's go see if we can get you some help, okay?
All right, this video provided a nice overview of some of the specific skill sets that we'll talk about in a little bit, the paraphrasing and the I statements. What I want to ask you about is the observable characteristics of Mary Ann. What did you see from Mary Ann's behavior that would put this in the category of a special populations encounter?
Loss of trust and personal safety.
Yeah, that she was feeling a loss of trust and personal safety. And use behavioral language. What did you see from her? How was she exhibiting that?
Angry.
Especially at first, she was throwing, I don't know, newspapers or something at the officer. So angry would be kind of loss of control. As the officer got in there and started communicating using his verbal communications, what was she doing? What information was she giving, and what was the behavior that you were seeing?
She was speaking of the dislike of her medication that she was taking and how it was making her feel.
Right. And what was she doing behavior-wise?
She had her hand to her mouth, some type of side effect from medication.
kind of was showing that, was talking about how she didn't like the side effects of her medication. What we characterize her behavior as is loss of perspective. This would be nervous, panicky behavior. So it's not anger like I want to fight. It's more fearful and panicky or anxious. It's not sad. I mean, she wasn't, I wouldn't put her in the category of a suicide risk. We'll talk a little bit about, she did say something in there about her brother trying to poison her. Don't know the brother, so we can assume that he's not, and that maybe she has a little bit of delusional thinking. But for the most part, what the officer has to de-escalate is what she's exhibiting. And that's what we call this loss model, the 4 loss categories. The whole focus is setting the officer up on walking into a scene and within 5 seconds being able to kind of categorize the observable behavior as one of those 4 loss categories, and then using a nuanced skill set to try and de-escalate them. So loss of perspective, we call that perspective because there's still people that are anxious or panicky are still in reality. They haven't lost reality. But it's more behavior related to apprehension and dread, and sometimes with these maybe even physicalness, heart palpitations, usually a lot of energy with these encounters. If you contrast that with the loss of hope, where it's very difficult maybe sometime to even get them to be verbal. These folks can have rapid speech, can be wanting to tell you all about their anxious and anxiety. So this would be the 4 characteristics of any special populations encounter an officer can have. Again, the emphasis isn't on the clinical diagnosis. It's behaviorally related, observation related in terms of what an officer would see. And it sets up 4 profiles that an officer has to de-escalate. One of the things we heard from Sally Ann is, my brother's trying to poison me. We generally call that, and let's assume he's not, we'd call that delusions, false beliefs. So with this model, you can have someone who is out of touch with reality, but how are they exhibiting the behavior? In Mary Ann's case, very nervous energy. You could have, an officer can arrive on the scene, suicide 911 call, they get to the scene, and it's a 33-year-old male. Officer starts talking to the male who's sad, depressed, and despondent. After a little bit, the subject becomes pissed because the officer's going to stop him from doing what he wanted to do, and it can escalate then into loss of control. It's all based on the observable characteristics that they're seeing. So these aren't static. These aren't concrete. These could be fluid behavioral profiles that a subject can go through even within an encounter, as we just had that example of a male who is suicidal and then angry that his plan to kill himself has been disrupted. And what the model will do is set up the de-escalation skill set. How you engage someone who's ready to commit suicide and how you engage someone who's ready to fight is different. And that's what I mean by a nuanced skill set. It helps the officer kind of really quickly assess the universe, if you will, of special populations encounters and begin to drill down on the de-escalation skill set that will hopefully end in a safe resolution. So let's test this model. What does PTSD look like? How does that exhibit itself?
Confusion.
Could be. Yep. That's one of the characteristics.
Anger.
Scared.
Destructiveness.
It could be all of these. You could have, I mean, ironically, PTSD is an anxiety disorder. And so you could have, with the flashbacks and the fearfulness of a trauma experience or war experience, you could have someone who exhibits it that way, anxiety. You could have a veteran who's pissed, who feels the military let him down and he's back and the transition is really tough, but he's displaying it in anger and in destructiveness. You could have a soldier with PTSD that's back who's suicidal. So the model cares less about the clinical diagnosis of PTSD and more about how are they exhibiting it. Some of you went through EXD training, excited delirium, yesterday. What does that look like? What's a subject with excited delirium look like? What are they doing? Are they here? Are they quiet, sad, withdrawn? They're in touch with reality, generally. They want to fight. And they'll fight one of you or six of you. So we could kind of see how this model looks at less, again, the clinical language of the diagnosis and sets up recognizing special populations. That's what the first thing this model does, is officers can recognize when they're in a special populations encounter. Again, diminished capacity, medical encounter, it will look like one of four ways. And when you think about it, the last time you were in crisis, we'll take this one out and we'll just say more confusion or disorganized thinking. But when you and I are in an emotional crisis, the range of emotions, the way we could exhibit it, are very limited. I could be pissed, I could be sad, I could be fearful, or I could be anxious, with all of this other behaviorally related stuff that comes with it. So we talked about PTSD and excited delirium. What do you think alcohol and drugs does to that model?
Sure mixes it up, sure.
And the question then back is, it depends. It depends on, are we dealing with an angry drunk? Are we dealing with a sad drunk? You know, it's going to be how the person is exhibiting their inebriated state. One of the things I will say about vigilance, though, about keeping it, making sure that you're staying vigilant, even though I'm saying medical encounter, don't ever lose the vigilance. It's said that a wise CIT officer can always conceal their combat-ready stance. Alcohol and drugs throws a lot of unknowns into it. Very, very unpredictable, especially if you don't know what they've taken, how much they've taken, and a whole range of possibly medical issues that could come in with interactions and reactions if they've had multiple drugs or are having a reaction to it. So with alcohol and drugs, while the officer's still going to arrive on the scene and the person's going to, like I said, be a happy drunk, be a sad drunk, that's what they're going to have to de-escalate. But just keep your antenna up when we're dealing with someone that's outwardly, you could tell that they're inebriated or have taken something, because they can be much more predictable, or excuse me, much more unpredictable. So we just looked at each encounter, and one of the things about this model is all of these behaviors, these emotional crisis states, exist themselves on a continuum. An officer can get to the scene and be dealing with someone who's not in touch with reality, or like that first movie we saw, that gentleman was really sick. His psychosis was pretty deep. And so this exists kind of on a continuum. Folks that are out of touch with reality, you know, it's kind of a misnomer, because they probably have one foot in reality. As you saw in that movie, officers still were able to get some information out of the guy. Generally, they could still give you name, maybe an address. Again, it exists on a continuum, but for the most part, you are able to use verbal de-escalation skills. If you can't, then that's another whole scenario where you're looking at your threat assessment. Same with angry and irritable. Officer could arrive to the scene and someone is pissed, but they're not ready to fight. They don't have clenched fists. They're not getting squared off. They're just pissed. And they're letting you know why they're pissed. So it's verbal and it's loud, but they're not showing any indication they're ready to fight. Existing on a continuum, it could get to the point where you are looking at flushed face, clenched fists, someone squaring off, someone who's ready to fight. Sad and despondent, not all of these would be suicide calls. This is on a continuum as well. The officer can encounter someone who's bummed. At the other end of the continuum, they can be dealing with someone who's talking about ending their lives, or maybe in the process thereof. And same with the loss of perspective. The anxious and nervous behavior. On the other end of the continuum is a full-blown panic attack. So what we say with the de-escalation training is the blue, that's really where it's challenging your de-escalation skills. That's where you need to be more vigilant, your antennas up. But it's important to kind of think of these not only as fluid states, but that these also exist on a continuum themselves. And part of what you're doing with your de-escalation is taking the time to communicate to find out, say, where someone is on the sadness scale, if you will. In fact, you need to rule in or out suicide thinking. Angry and irritable, usually that one's a little bit more apparent, but again, could be unpredictable, so stay vigilant. On the blue side is where we're telling you to stay very vigilant with these types of encounters. And we already talked about Marianne a little bit, how she talked about her brother trying to poison her. Again, you can have someone that can go into these different states even within an encounter. So the whole idea is to define special populations by what an officer's got to de-escalate, by what an officer sees. This is it. And so it is important, maybe, to know that a person has PTSD, because then the officer might be able to use that as information when they're de-escalating. Maybe ask about if they've served their war experience or their military experience. So I'm not saying it's irrelevant. I'm saying the focus really needs to be on which of these 4 de-escalation profiles is the officer walking into, and then use the skill set needed to address that. We're now going to make a shift. The whole loss model was on recognizing special populations. Now that we've done that, we're going to start getting specific about the de-escalation. In every encounter with special populations for officers, there's really 3 phases we want them to get safely through. You need to engage the person. That's just a word for gaining rapport. You need to test how much of your verbal communication you can get and give. And it's usually decided or started certainly within the first 5 seconds that an officer arrives on the scene. But this is the ability to gain rapport. You want to gain rapport so you can get information and resolve the whole encounter peacefully. That would lead to the second stage. You need to assess what's going on. You're still an officer. Was a crime committed? You need to rule that in or out. Since we're talking about diminished capacity, you're ruling in or out kind of what's going on with the encounter. Again, not in clinical terms, but if it's a loss of hope encounter and suicide's at play, one of the things you'll be doing in your assessment is determining how serious of an intent that is for the person. And the resolution stage. The assessment and the resolution stage, it's pretty black and white. I mean, the assessment is the interrogation, if you will, the questioning, and depending on what you learn in the assessment phase, if a crime was committed, if the person might meet commitment criteria, the resolution stage is pretty black and white as well. So we're going to spend most of our time on this. If you can successfully engage in a de-escalation encounter with special populations, then the assessment information will come forward. By successfully engaging, you've gained rapport, you've gained trust, and you're getting the information you need to move through the other 2 phases. We talked about the engagement goal to gain rapport. We kind of use this as the picture of the difference between command and control. Again, first 10 seconds, arriving on the scene. We talked even about how officer presence can escalate. So we're really starting to cement the mindset of patience and empathy as the backdrop for how you engage someone. We talked about how you present yourself. You saw in the video, you didn't see in the video, we'll look in a minute at a post video of those 2 officers and after they've gone through training, and you'll see how using the person's name, that was mentioned in the Georgia video as well, it's personal. Asking for that person's name and using it often. Again, the goal, establish rapport. Use your communication skills to do more than just kind of use command and controls in the situation. State the reason you're there in a way that can build trust about the situation. I mean, you're a peace officer. You're there to help. For someone who's anguished, if you think a loss of perspective, for someone who's deeply sad in loss of hope, you being there and letting them know you're there to help can be what you need to establish rapport in that encounter. Be careful with scene management. You know, with the loss of perspective, where we have someone who's panicky and anxious, it might be more important to remove people depending on what they're keying off on. But each of the 4 profiles, if it's a suicidal one, if the person who's caused them anguish is there, you just need to kind of think about scene management as well as while you're building rapport so you can see what would help you reach that goal. So the goal in all of these is to calm. All of them, the goal is the same. To calm someone who's angry, to calm someone who's anxious, to calm someone who's frightened and frustrated, or to calm someone who is thinking about suicide. And again, the skill set that everything comes from is patience and empathy. We say patience because these situations take time. What we're telling you is beyond command and control, you're going to have to take the time to communicate. Active listening, all those things that you were taught in your interpersonal communication classes, paraphrasing, you saw some of them on the Georgia video, that takes time. And you control time in these situations. So we want you to be very cognizant of that. But patience and empathy are really the backdrop. And because we've, of all the universe of special populations encounters, we defined it into 4 categories, you begin to see how the skill set is nuanced. Basic skill sets, I mean, it's not rocket science in that sense. We're talking about your ability to listen, clarify, understand. We call it the communication web. We don't go into a lot of detail with that. A lot of you already have had training on interpersonal communication, but this is still the skill set you're using. And so if the goal is to calm, and we're dealing with loss of reality of someone who is confused and disoriented, one of the things you want to try and do is use their name, offer your name, but ground them in the here and now. And we'll see in a minute a video of how the officers are able to repeatedly use the person's first name to bring them back as he's kind of going in and out of psychosis. But again, they're confused, they're reacting to hallucinations. You are a calming presence. And one of the ways you move to the assessment phase is being able to let them know you're there to help and ground them in the here and now. With loss of control of someone who's angry and irritable, listen. They'll tell you why they're mad usually. It's pretty clear to them why they're mad. They probably want to tell you why they're mad. And you can deflect if they start to make it a personal attack on you. You're the professional. You know it's not personal, it's in the heat of the moment. So don't get caught up into arguing back with them. For someone in loss of hope that's sad and desperate, especially if they're at the farther end of the continuum where we're talking about suicide, you only need to instill hope within the encounter. You don't need to solve their problems. If someone is sad because of a loss of a loved one, a loss of a job, you're not going to solve that. What you're trying to do is really get them to step off the bridge, or whatever their means of suicidal thinking and intent is. You're trying to instill hope long enough that they would agree that you should call a mental health professional or take them to the emergency room or whatever the protocol is for you to deal with someone who's suicidal. Loss of perspective, the anxious and panicky. You want to calm. Again, the goal on all these is to calm, and you do this by redirecting if you need to, listening to them, reassuring them, again, you're there to help. Now let me give you an example of why we never say never with de-escalation skills in CIT. Generally, it's a good idea when we're talking about de-escalating people is to let them vent. Let them get out of their system why they're angry. I would argue that that's a really good tactic for this, because you could even physically see someone deflating as they're getting the anger out. I would argue you have to be very careful, though, with loss of perspective. You could have someone who's anxious, and the retelling, and the retelling, and the retelling, which they might want to do, will make them more anxious. So if they're fearful about medications, if that officer just kind of let Sally Ann go on and Sally Ann wanted to keep talking about the medications, I could see Sally Ann getting escalated. So, you know, it's really difficult for us when we say never or always. It really now starts to be nuanced based on, well, what am I trying to de-escalate? And then I'll have a better feel on what I should and shouldn't do. We're still in the engagement strategies, and this is really, if you think about the first 10 seconds that you arrive on the scene, we call it modeling. You're modeling the calmness that you want to get from the person. We're not saying the person's calm yet, but the more you stay calm, the more you stay in control, the more effective you'll be at getting your message out, at verbally de-escalating, and hopefully reducing the level of tension that the other person has. So this probably wouldn't be a good picture to think about when we say modeling and mirroring, because the finger in the face isn't necessarily something that would de-escalate someone. So be very aware of your body posture, your body stance, your tone of voice. Again, if you think patience and empathy, some of that should come naturally. You wouldn't necessarily be in someone's face if we're thinking about patience and empathy. So modeling and mirroring, individuals in crisis will reflect your vibe. We're wanting your vibe to be calm. Again, that's your goal. They aren't there. Your job's to bring them down. A word about empathy, since it's so key in establishing rapport. And even in, again, the first 10 seconds, a lot happens in the de-escalation. Your ability to state your name, get their name, begin to use it, listen. Empathy absorbs tension. Again, the goal is to calm. One of the ways you do that is by being empathetic. It's a sponge in that sense. People can relate to that. They're feeling listened to. It conveys understanding. It begins that idea of rapport. It creates a connection. And all of this works for the ultimate goal. What we want is to calm the individual. We're going to move to the assessment phase. This is kind of the black and white where you're trying to figure out what else has happened. So you had 911 information that you got through dispatch. You've now calmed the person to the point where you're getting information. You're going to rule in and out whatever the special population's characteristic is. Autism, Alzheimer's. Again, if they tell you that, great. Ask about medications. If you don't know the name of the medication, ask them what they take it for, because generally they could tell you, I take it when I'm sad, or I take it when I'm hearing voices. But the idea is that you be able to figure out, knowing it's a special populations encounter, kind of some of those characteristics that make it such. You'll have to rule in or out if there's medical issues going on. You know, you might happen upon a seizure and or someone who's taken alcohol and drugs. And of course, whether or not a crime was committed. So again, the assessment phase is more what you're comfortable doing. It's kind of the questioning and interrogation to get the information that you need once you've calmed the person down. If it's loss of hope, obviously you have to assess lethality. We'll talk a little bit more about that in a minute. Talk to others at the scene. They can be great sources of information, especially if it's family members. Family members will know. Generally, if their sons or daughters are taking their medication, they could tell you what the diagnosis is. They could tell you who the doctor is they see. They are a wealth of information about the last time they went to treatment, possibly even numbers of case managers and people like that. So use them as part of your assessment information, especially the more the person is nonverbal or really sick, out of touch with reality. If there's others at the scene that can convey information, then use them. The resolution goal, you've built trust, you've got the person calmed, you've got the information you need around crimes, around alcohol and drugs, around the special populations encounter. You now need to decide on your course of action. What are you doing? Generally, in special populations encounters, there's a technique called forecasting. That's really good to do to keep the person calm. And that's you telling them in advance of you doing it what you're going to do. So I'm going to have to put my hands in your jacket pocket to check for any weapons. Is it okay if I do that? And it sounds like you're negotiating the next steps, but you're actually kind of walking the person through. It's our policy here that we're going to have to handcuff you. You're not against the, I'm not taking you to the jail or anything, but I do have to handcuff you. So forecasting kind of keeps the surprise level down and helps you still maintain the calmness that we want you to maintain. And then leading them, another technique for resolution. Here's what I'm going to need you to do. I'm going to need you to follow me over to the car, or I'm going to need to call a mental health professional who's going to come talk to you. It's kind of like forecasting, but it's leading them to the resolution. Again, when you think about our 4 profiles, loss of hope, someone who's suicidal, barely verbal, you might try and engage and find you can't get much information, and you might have to start working on your resolution. If you're not able to get information from someone, if they're so despondent and they're so sad, you might just start leading them to what you need. I'm going to need you to come with me. I'm going to need to call a mental health professional. And you just let them know how you're bringing it to a resolution. So forecasting and leading kind of help keep the calmness that you worked so hard to get still down. There's a couple different scenarios for your resolution depending on your assessment phase. So it could be an informal resolution. Officer arrives at a scene. It's a loss of hope category, but they're not suicidal. They talk with family members. They're going to be all right the rest of the night. The officer leaves. That's an informal resolution. No crime was committed. It wasn't a domestic call, so there was nothing to investigate there. Person might have medical complications, so part of the resolution might be an emergency room. Or depending on what your local protocols are in accessing mental health backup, it could be mental health, hospital, or jail. And we actually have the officer decision matrix, which kind of plots this out. Again, in your assessment phase, you're asking, was a crime committed? We put misdemeanor up here because felonies dictate you will do what you need to do. But where you have officer discretion, and you have officer discretion on misdemeanors, that's the first thing we're looking at. The second is, do they meet the commitment criteria in your state? That's generally, by commitment criteria, now we're talking about an inpatient psychiatric hospitalization. Generally, there's some sort of dangerousness standard, danger to self, danger to others. And so the officer is really looking at where does the person fit on this category, and it brings up kind of the 4 different quadrants that underscore the different resolution that an officer can take. So they meet the commitment criteria and a misdemeanor crime was committed. The officer's going to have to figure out, and we hope since this is a jail diversion program, that we're really not looking at this, more so looking at calling for a psychiatric assessment to see if we can treat the fact that they meet the commitment criteria. Yes, they meet the commitment criteria, but a crime wasn't committed. That's pretty black and white. No, they don't meet the commitment criteria, and yes, a misdemeanor was committed. Again, because they don't meet the commitment criteria doesn't mean diminished capacity isn't in play. It's still in play. So the officer must distinguish between criminal behavior from conduct that's a product of diminished capacity or mental illness, but has no criminal intent. And then the final category would be no, they don't meet the commitment criteria, and no, a misdemeanor crime wasn't committed. So this is more of a framing of the different decision points an officer can make, and we just really stress here when we're talking about crimes being committed that we're really using jail diversion where we can, so that we're not losing the person and they're not getting necessarily the treatment that they need in outpatient non-jail settings. When we do trainings of law enforcement officers, before we put them through our 40-hour training, we always do a pre-training survey. And one of the questions we ask every officer is, when you think about your encounters with special populations, what are those encounters that you feel the least prepared to de-escalate? Almost unanimously, 2 types of encounters come up. Those where subjects are out of touch with reality, and those suicide encounters. Obviously, weapon encounters, although ironically that's probably where officers have the most training, is in force. So I wanted to say just a little bit about de-escalating psychosis and de-escalating suicide. If someone's psychotic, like we saw in that first video, demon spike in the back of my neck, a brain chip, there's 3 responses an officer can make. An officer can, trying to calm and de-escalate. An officer can act as if they believe. So if you were the gentleman in that video and you presented me with, are you putting a demon spike in the back of my neck, or are you putting a brain chip? You know, I could say, no, but you know, if you were worried about a brain chip being there and then try and de-escalate you, buying into that. I think I could calm you down if you think I believe what's happening, because then you'll trust me. We ask officers to think about the pros and cons of that, though. You could meet that person again later, hopefully when they're healthier. Even when they're sick, they kind of know their way they see the world and the voices they're hearing isn't quite right. So you risk some credibility, especially if you have an encounter with them again. Another drawback is if I act as if I believe you, then you would expect my behavior to be really consistent with that and try and help you, whether it's to get the chip out. If you were worried that they were trying to poison the water supply in Las Cruces, and I'm like, yeah, I heard that too, why don't you come with me? You got to help me stop this. And I would try and elicit your help, try and elicit the officer's help. And so it puts you in a really precarious situation that once I realize you're not really helping me, can escalate the situation. So it makes the resolution phase more difficult. So act as you believe them would be one option. Another option is I try and talk you out of it. There's no demon horn in the back of your neck. There's nobody putting chips back there. You run the risk of escalating the situation, because now as a subject who's loss of reality, you're one of them now. You're the ones that you're part of the cover-up, you're part of the conspiracy. My ability to, what's our first goal? Gain rapport, has just possibly been damaged. So trying to talk them out of it, again, loss of reality, the brain is compromised, it's sick. So the logic components aren't always firing on all cylinders. So the ability to talk me out of it isn't highly successful. Logic and reason can't penetrate, and again, it makes the resolution phase difficult. So if the 2 options we covered are I could act as I believe you, or I could try and talk you out of it, aren't what we recommend, what's the 3rd option? Well, you try not to go either way with it. You defer, you avoid their perception of reality. You don't get sucked up into it. So a de-escalation strategy they may have used in that first video was, again, patience and empathy. You can always express empathy. You don't have to have experienced psychosis to express empathy. So are you putting a demon horn in my back of my neck? No, sir, and you know, I could see why that would be very frightening to you, but that's not me. I'm here to help. Reflect back to them the state that he's showing you, everything that made him confused and disoriented. But take control of the conversation. Here's what I need you to do, sir. And try and start leading and forecasting them. Now, we do want you, if someone is hearing and seeing things, to ask about that. We're not saying avoid the subject. It's very, very critical assessment information. If I'm hearing voices, ask me, what are they saying? Are you hearing them now? Because if I tell you I'm hearing my deceased grandmother and she's wishing me well, that's a little different than if I'm hearing a satanic voice telling me to take out some people. And you know what you're dealing with based on my perception of reality. Same if I'm seeing things. Ask me what I'm seeing and use that as your assessment information. Just don't buy into it. Don't try and talk them out of it. Don't try and minimize it. Kind of defer or deflect your belief in it and make it about, boy, that must be really frightening for you. I could see why you're worried, but I am here to help. And then try and take the conversation back. The suicide block, we think the officers on the pre-training survey, well, we know this because we asked them. When we ask them why about psychosis, that's their issue in terms of where they feel least comfortable. Do I buy into it? Do I talk them out of it? And that's why we set this part of the training up. With suicide, there's this misconception about talking about it. what do I say? Or saying the wrong thing, worried about that if you're involved with someone who's suicidal, that what comes out of your mouth can actually cause them to be suicidal. And if we think about the ultimate, the bridge jumper, where the results are immediate based on how successful or unsuccessful you are with de-escalating, it makes sense. So we generally say with suicide, you got to ask about it. Again, as part of your assessment, you've got to figure out how serious they're thinking about it. And one of the best predictors of that is past behavior. So part of your assessment, if someone's saying, I'm thinking of killing myself, would be, have you tried this before? If the answer is yes, how recently? All of that's critical assessment information. But generally we say, you've got to talk about it. So the issue of should I talk about it isn't on the table. You need to get critical information. Remember, medical encounter means your assessment phase is trying to get key information about their state of mind to give to someone else, a mental health professional or a medical professional. All of these encounters are in a negotiation. If you think about it, all of them, we said the goal is to calm, and you're trying to negotiate the situation down. Again, the voluntary compliance is what we're trying to get. With suicide, we talked about the loss was a loss of hope. And you win the negotiation to the extent that you could restore any hope within the encounter, just long enough for them to swing their leg over the bridge, then swing their other leg over, and then step down. And that's why we key in on patience and empathy. It takes time to penetrate some of these emotional crises with your verbal de-escalation skills. That's the patience. And it goes back to modeling and mirroring. If you're patient and empathetic, you are able to calm the situation more than if you're authoritative, command, and control. Ideally, you regain control by using empathy to restore a sense of hope and have the person voluntarily, that's the goal, voluntarily reply or comply with your requests. The suicidal mindset, there is so much going on. If you think about it, I've reached the point in my life where I have so much pain from fill in the blank. A loss of a loved one, a divorce, a loss of job, a loss of money. So much pain that my problem-solving skill is I know how to end the pain. The frame isn't so much I need to kill myself. The framing is I know how to end the pain. And so most people, who want to commit suicide are very ambivalent, because in a logical way they know, well, I am ending my life. If that's what I'm thinking of, ending the pain, it would end the pain, but it would end my life. Very ambivalent about that. We teach officers to use that ambivalence. They can use that by listening to what their anguish is and then trying to make a personal connection with their story. So the mindset, it's hopelessness. They think they've tried everything, or their self-esteem is such that it isn't worth going on, and they're now thinking about making the decision to kill themselves. And that's the mindset of someone who's suicidal. If they're ambivalent, it means that part of them wants to live. That's what you're trying to connect with. That's how you try and instill hope within the encounter. So you want to use your ambivalence to your advantage. How do you do that? If you can get them talking, they'll tell you usually why they're sad. They'll tell you what's happened to them. It could be a divorce situation. It could be a loss. And you may or may not have a personal connection. You may or may not have gone through a divorce. But the ability for you to make some sort of connection with their pain in a way where you can reflect either empathetic statements like, God, that sounds terrible. You know, I understand. I could see why you're really sad. But you know, I need to at least swing one leg over so that we could keep talking. You're always negotiating safety while you're giving the empathy. But if you can make a personal connection with their story, you know, I went through a divorce too. I'm here to tell you that I've worked with other people that were, you want to be careful not say, I know what you're feeling like, because you'll lose credibility with them. But the way you go at that is to say, you know, I have worked with other people that were very, very despondent like this, and I'm telling you, there's help. And we could begin the process of getting help right now. That's what you and I can do. I know it doesn't feel like that there's any chance for you, but I am here to help, and we can start that process now. And that process is getting them off, getting them to the appropriate mental health professional or mental health facility. Don't avoid the elephant in the room. I don't want you to die. Well, what do you care? I'm a peace officer. I'm a police officer. I care. And I'm telling you, I've had encounters where people have gone on and gotten over this. And I want to make sure that that can happen to you too. So go ahead and talk about it. Listen to their anguish. When we do our 911 trainings, we actually listen to 911 tapes, and we had a suicidal caller who began the conversation with, "I have a gun to my heart." That was the words that the dispatcher heard. Man was depressed. Man was suicidal. She wasn't getting a lot from him. He really kind of sounds like he had made the decision, though he called, and that's ambivalence. The dispatcher did a really good job and picked up on the only thing he was saying was, I put my dog in the other room. She started asking questions. What type of dog? He started telling her. She had tried several other ways to bring information out of him, but connected with the dog. So that's that personal connection. Listen to what they're telling you and see what you can try and use. And a lot of this is kind of hit or miss. I mean, this is the art of de-escalation. You try this. If it didn't work, don't keep trying it. Try something else. She went through 3 or 4 things. I think it was over a relationship. She tried to do that, and that wasn't working. And it really wasn't until she found some common ground with the pet that he was able, and that situation resolved well. And that's how you attempt to make the personal connection with their story. So breaking through the isolation and helplessness, you are there for them. You are a peace officer. I began this whole presentation by saying that law enforcement is the first line of intervention for special populations. Sometimes you're the first line for someone who's suicidal. Use that to your advantage. You're there to help. You're in a position to help. You're in a position to get them to the pre-screener or get them to the emergency room. Tell them they can begin to ease the pain by working with you now. Again, you're in the minute with them. You're not promising to solve the problems. You're just trying to instill enough hope that they'll come with you. They'll voluntarily come with you and believe the words you're telling them that this can change. We can get help, and using your past experience to validate that with other people and model a compassionate and caring approach. So we have covered who you are. Patience, empathy, vigilance. Never lose the vigilance. Particularly loss of reality, loss of control. Those can be very unpredictable. Loss of hope when someone has a weapon, maybe a bladed weapon to their own throat or a gun to their own head. Very, very unpredictable. So never lose vigilance. That's who you are. This is what you do. You communicate. And we've talked specifically paraphrasing, active listening skills. All of this coming from that context of patience and empathy. We don't spend a lot of the time on the do's and don'ts. Don't argue, don't name call. Because if you're patient and empathetic, that's not in your toolkit. Don't call names, anything like that. Who you are, what you do, and how you do it. Engage, assess, resolve. So the goal of the communication skills is to get through those 3 phases of every encounter. So to summarize, what every officer needs to know is what you say and what you do matters. We talked about the 4 encounter types: loss of reality, hope, control, and perspective. This is a way to 1, identify a special populations encounter, and 2, begin to think about your de-escalation strategy. These are medical encounters, and use of command and control techniques can escalate the situation. The 3 phases we talked about, remember your goal is to calm, patience and empathy being your mindset in which you deliver your communication skills. The 2 safety skills, patience and empathy, remember the de-escalation paradox. The less authoritative, the less controlling, the less demanding, you actually gain more power and control in these situations. It's antithetical to how you were trained for those other 90% of your calls. And the 1 survival skill of vigilance. All right, we're going to look at some officers that put it all together. They've gone through the training. We're going to go back to that very first encounter we had with the gentleman who was holding the Bible. What I want you to key in on is the depth of their de-escalation skill sets, the depth of their communication skill set, particularly when we think about engagement. Tick off some of the engagement strategies you're seeing in this scenario.
I am from the tribe of Issachar. Daughter of Baal, be baptized in the blood of Christ. Son of Adam, let Ishmael speak to you. Let him bring you to the great Muhammad. Be one with us. Be one with us, son of Adam. What are you doing? What are you doing?
Sir. Hey, I'm
What are you
Officer
doing?
Lee
Get back.
with the
Get
Houston
back.
Police Department. This is my partner, Officer Barry.
Stop.
What's going on out here today?
I'm here to preach the word of Satan. I am the son of Satan.
Okay.
You
You okay? Are you okay? You look kind of nervous.
You're all from the government. It's a big old plot.
No, I'm Officer Lee with the Houston Police Department. It's my partner, Officer Barry. We're here to check on you. What's going on today?
I've come to preach the word of God to the many that don't believe. I am the son of Satan. I've come to baptize everybody in blood.
Are you okay? How are you feeling? You have any physical problems? Hey, what's your name, bud? What's your name? Can you tell me your name?
What do you want to know? Are you going to hurt me?
No, I'm not going to hurt you. No one's going to hurt you. I just want to know your name so we can talk. I'm concerned about you. There's some people concerned about you. We came out here to check on you. Who are you talking? Are you talking to someone? Are you hearing voices?
I hear voices all the time.
What's your name, sir?
Mark.
How you doing today, Mark? I'm Officer Lee. This is Officer Barry. Mark,
Yes.
you are hearing voices.
Yes. Hey,
Does this happen a lot?
19 years of my life has been stolen from me. They stole my soul in the
Mark.
hospital.
Mark, Mark,
Hey.
Mark, Mark.
Hey.
Do you take medication for this, for the voices?
Hey.
Mark, can you look at me? I'm trying to help you here, trying to find out what's going on with you. Do you take any type of medication for your problems, for the
I
voices
don't take
you hear?
demon drugs anymore. They steal your soul.
Not demon drugs. You take any medication to help you? The good medication.
Hey.
Do you have some medication that helps you with your problems?
Effexor.
Do you get this medication from a clinic, from a doctor? Do you have a personal doctor you see? Mark, look at me, okay? Do you get this medication from a doctor?
Hey. Yes.
Okay. When's the last time you took your medication, Mark? Mark. Mark, can you look at me? When's the last time you took your medication?
Last week.
Last week. Does it help you with these problems, with hearing these voices? Mark, does it make you feel better when you take your medication?
Yes.
It does. How about if we get you some medication today to help you with your problems? Mark, would you like to get some medication to help you with your problems?
I don't want to go to the hospital.
Now look, do you have a doctor you go see? Mark, hey, don't reach in your pocket, okay? What are you reaching for? Mark,
My doctor's card.
your doctor's card.
Hey.
All right. Well, just hold off, and we'll look at your doctor's card. Do you know your doctor's name? Mark, do you know your doctor's name?
Dr. Hammond.
Dr. Hammond.
Yeah.
Dr. Hammond gives you this medication?
Hey. Yeah.
When's the last time you saw Dr. Hammond?
A month ago.
A month ago.
Hey.
Mark, listen to me. How about if my partner and I take you to a clinic today? Mark, you need to listen to me. It's very important, okay? We're here to help you. We can take you to a clinic today. The doctors there will speak to you. They'll get hold of Dr. Hammond. I'm sure he'll tell them what kind of problems you've had in the past. Mark. And I'm sure Dr. Hammond will tell them what type of medication you need to be on. And they'll get you on your medication. Mark, how's that sound? Do you want some medication to help you?
I'm hungry.
You do?
I'm hungry.
You're hungry.
Hey.
They'll help you out at the clinic, okay? They'll get you something to eat. Mark,
Hey.
they'll get you some medication. They'll get you something to eat.
I don't want to be admitted.
Okay, Mark, I can't make any promises to you. Mark, listen to me. I'm not a physician. They're going to evaluate you down at the clinic, okay? Mark, you have a history of this problem. I'm sure all they're going to do is evaluate you and get you back on your medication to help you with your problems, okay? Does that sound good to you?
Yeah.
Okay, now look, Mark, let me explain something to you. You need to listen, it's very important. We're going to need to take you down there in our patrol car, all right? No one's going to hurt you. You're not under arrest. You're not going to jail. Do you understand, Mark? Do you understand what I'm telling you?
Yeah.
Okay. You're going to need to ride in the backseat of our patrol car down to the clinic, all right? Okay? We're going to take you down there and get your medication. Are you willing to do that?
Yeah.
Okay. Why don't you walk over here towards my partner and I. We're going to go over here to our car. Mark, listen to me. You need to walk over here towards my partner and I. We're going to go to our car. We're going to need to pat you down. Make sure you have no weapons on you before we put you in our car. Okay?
Get back.
Look, no one's here to hurt you, Mark. We're here to help you. Okay? No one's going to hurt you. Okay? Now, Mark, I'm going to be honest with you. Can we check and make sure you don't have any weapons on you? We're not going to let you sit behind us in the car. Mark.
Hey.
Okay? Do you have any weapons on you?
No.
No knives? Nothing sharp?
Hey. No.
Okay. Do you mind if we check? I promise you, I'm not going to hurt you. This is for my safety and your safety, okay? Mark, listen to me. This is for my safety and your safety, okay? We don't want anyone getting hurt. We're not going to hurt you. Mark, everything's okay.
Hey.
Okay? We're going to get your medication for you, okay?
Hey.
Mark.
Hey.
Is that okay?
Is
that okay?
Yes.
All right. Can you put your Bible down in front of you? Okay. All right. All I'm going to do, Mark, is I'm just going to pat the outside of your clothing and check, make sure you don't have any weapons on you, okay? Before you sit in the car. Mark, is that fine? I don't? Okay. Do you understand?
Yes.
Okay. Are you all right? Look, Mark, no one's going to hurt you, okay? No one's going to hurt you. What do you have in those pockets there? What's in this pocket?
So the officers successfully pat him down and get him in the car. So, talk to me about the de-escalation skills you saw.
Now, there was a number of things that they did differently. They introduced themselves. They kept a good distance. They didn't create a crossfire between the officers. They asked him questions and showed concern. Asked him about his medication. Asked him if it helped him. Asked him when the last time was that he took his medication. Asked him not to reach in his pockets. Explained to him why. They took their time.
And what was the backup officer's response when he started reaching for his pocket? He had hand over gun. Vigilance. Still don't lose the vigilance. That's key. Because we don't know what was in his pocket. Good.
They took their time with him, made no promises to him, and then they explained to him what he needed to do next so that there was no surprise.
The forecasting and the leading.
They were successful in the pat-down.
Great. Wow. I've never had anyone answer it so thoroughly. And you saw examples of the forecasting and leading. If the goal, this is loss of reality, if the goal is to calm, and you do that by grounding them in the here and now, what technique did the officer continually use as you saw Mark kind of go in and out of the conversation?
Use his name to get him back.
Simple technique.
Here and now.
He wanted his eyes, he wanted to interrupt the vocal utterances that Mark kept making. When Mark started doing that, he just went right to his name and kept grounding him in the here and now. And you saw examples of the forecasting about getting him into the patrol car and patting him down. Did take a lot longer, something like 7 minutes compared to the first one, which was, what, 2 minutes? Those officers were out on the street pretty quickly. But again, if we look at it from the lens of a medical encounter and safety, I would argue the ability to pat down someone voluntarily is much safer than having to go hands-on before you know what's under the jacket. Any questions about that? I think I wanted to end with a few numbers. One of these is the number of officers killed in the line of duty every year. The other is the number of officers shot and killed in the line of duty every year. Anyone have a guess what the 40 to 50 is? Killed in the line of duty or killed in the line of duty by gunshot? 40 to 50 officers are shot and killed each year in the line of duty, and around 150 police officers are killed in the line of duty. That includes gunshot wounds and all others. So we've got big range here of around 141 to 200. Anyone have a guess what that is? Number of law enforcement officers who commit suicide each year. You guys are dying at a rate at your own hand more than you are in confrontations with citizens out there. It's really critical that as we talk about mental health and mental illness and PTSD, that you look at your own life work and your ability to create balance in your life. This is a number we have to take down. The majority of these occur after retirement. So if there's anything we could give officers that are new or old, just starting the force or getting ready to retire, it's your ability to keep balance in your professional and personal lives. It's your ability to hold on to what nurtures you, those relationships, your wife, your kids. Those are your pivot points when life is stressful. You have, just as military, you have a very, very stressful career. Often with officers, because of the chronic stress that sometimes leads to burnout, they talk about it as being suicide by inches, chronic stress. So your awareness of what you got through this training on mental illnesses, and as you heard from consumers and family members, your takeaway from this is if you need help, use those around you and nurture those relationships. And if you need professional help, get it. Use your EAP. Go to trained officers in your departments and begin asking them how you might get help. But you got to take care of your